want to welcome you to the 13th annual um, Fall Conference of the Prostate Cancer Support Association of New Mexico. I am the board chair. My name is Rod Gear, and I really welcome all of you for coming, taking the time out of Saturday. One of the things that I believe we are sure of is that when you leave today, you will know more about prostate cancer than when you arrive. I also want to thank all of the folks out in the audience who I recognize who have contributed during the course of the year in a variety of ways. Very much appreciated. Thank you. One of the things that has occurred over the past year is that our twice monthly Saturday meetings at the Bear Canyon Senior Center, we have essentially doubled our historical average for people attending the meetings. The other change for these meetings is that we now regularly have probably 4 or 5 couples attending, which sort of adds to the energy of the discussions. Also, want to thank all of the folks who have dipped into their wallets and piggy banks and been so generous with your donations during the course of the year. That just has helped us tremendously, and you are all so very generous. I now want to turn the mic over to the suited Jonathan Brown. He is going to go over with you some of the things that we're going to talk, some of the sponsors and other information that you need to know about today. So, Jonathan, turn.
Welcome to the Prostate Cancer Support Association of New Mexico's 13th annual conference. I am Jonathan Brown, and I'm a volunteer here. I'll be your moderator for this event today. Thank you all for being here, and we're grateful for your presence and support and the generous support of our sponsors, including our Platinum Premier sponsor, Pfizer. Our silver level sponsors are X-Ray Associates of New Mexico and New Mexico Cancer Center, New Mexico Cancer Center Foundation. And our bronze level sponsors are UNM Comprehensive Cancer Center and Any Lab Test Now. This event would not be possible without their generosity and without you, our audience. We also owe our gratitude to the talented panel of presenters who are graciously sharing a part of their weekend with us. We're honored to have them here today. And last but not least, thank you for the amazing volunteers who have given their time and worked hard to make the upcoming valuable presentations available to our community. A few last details before we begin. Please enjoy all of your refreshments in the lobby, and food and drink are not allowed in the theater. Be sure to visit the exhibitors in the lobby. They offer valuable information and resources. One of our exhibitors and sponsors, Any Lab Test Now, has donated 4 vouchers for PSA tests. If you would like to be entered into a drawing to win one of these vouchers to give to someone you'd like to encourage to get the PSA test, please drop by Any Lab Test Now table for more information. We will hold a drawing after the conference, and you need not be present to win. We also have evaluations in each gift bag, and we invite you to provide your feedback and ask that you place them completed forms in the box at the registration table out in the lobby. We'll have time for 1, possibly 2 questions for each presenter at the end. Please keep all your questions brief and general to ensure that the answers are relevant to the audience and not to just any one person. Our first presenter is Dr. Laura Mihalko, the urologist at Raymond G. Murphy Veterans Administration Medical Center here in Albuquerque. And her areas of focus are prostate and renal malignancies. she will speak on the role of testosterone in diet in prostate cancer.
Hi, everybody. Thank you to the Prostate Cancer Support Association for inviting me. Some of my patients, I won't name names, have threw my hat in the ring for speaking here, and I appreciate you making me get out of my comfort zone because public speaking is not my favorite thing to do. But we're gonna learn some fun things today. I've got my point. That's okay. Um, thank you for that introduction, Mr. I appreciate that. I'll get, the beginning parts of my slides are just the intro. So I'll just start talking just for time purposes, just a little bit. I don't have any disclosures. I wish I did. No one pays me outside the VA. And then this is not directly, endorsed by the VA or the UNM residency program, but those are my affiliations. I'm a staff urologist at Raymond G. Murphy, and then I'm one of the core faculties for the University of New Mexico urology residency program. And then some of the things we'll talk about. Okay, perfect. No, you're fine. I'll make sure we're gonna. Perfect. Okay, let's see. We're going back. Okay, got some animations. Okay, and then we talked about that. Okay, great. So some of the things we're going to talk about the physiologic role of testosterone. Let me just change something on this computer because we're going in tangent so I can read better. Okay, great. So physiologic role of testosterone in the body, testosterone and prostate cancer growth, symptoms of testosterone loss, and then we'll talk about replacement for patients who are more on active surveillance or in the post-treatment phase, post-surgery, post-radiation. And then a little bit on some of the current literature for high-dose testosterone as a therapy, and then diet and prostate cancer. All right. So, the urologist in prostate cancer, we have a lot of involvement with the patient. There's lots of points of contact. We don't just remove prostate. Prostate cancer screening falls on primary care and also the urologist. We help lead patients toward a biopsy, getting a diagnosis, and then the treatment surveillance decision-making process. Once we go through with a treatment plan, it's follow-up for surveillance for recurrence, and then also survivorship. How can we help patients feel better with some of the potential repercussions of the treatments they receive for their cancer? So testosterone, what does it do? It does a whole lot. Doesn't just build muscle, so there's a lot to it. From the very beginning, it's necessary in embryonic development. We all start off with the same set of internal organs right here, and then the presence of testosterone and another protein is what differentiates male and female phenotype. And so it's important. But saying it's a male, the male hormone also is a little bit of a misnomer because women need testosterone as well for libido, and it's an important female hormone for muscle mass as well. But the prostate really won't develop unless you have testosterone and you have a functional androgen receptor. So this is a nice chart, kind of goes through, hey, what does testosterone do in our body? We know it's important, but what is it even doing? So top, we've got red blood cell production. It is responsible for helping improve production of red blood cells. It helps maintain bone strength, helps support our immune system. When you're hypogonadal, it doesn't necessarily mean you're immunocompromised, but there is some functional role for testosterone in your immune system. And then it also, let's see, inhibits fat synthesis, so it absolutely does decrease the amount of fat that's being produced in our body. Inhibits nerve inflammation, so that actually comes into play for plaque-mediated dementia. So it actually inhibits plaque formation, alpha-beta plaque formation that's associated with cognitive decline, with memory decline. Promotes muscle growth, we all know that, and sexual function, that's not on here, but it's incredibly important for erectile and ejaculatory function as well. So here, testosterone, where does it come from? Obviously the Men's Health Clinic down the street. That's what I think we all feel. That's where a lot of people get a little extra. But in our bodies, men produce testosterone from two pathways. The primary pathway is going to be mediated from signaling in the brain. So the hypothalamus in the brain releases something called GnRH, gonadotropin releasing hormone. And that comes down to the anterior pituitary, where you get two extra hormones. You get FSH, follicle stimulating hormone, and luteinizing hormone, LH. And FSH produces sperm, spermatogenesis, stimulates that in the testicles. LH goes to the Leydig cells, and that produces testosterone. And then testosterone can then turn into estradiol, an estrogen, or it can be activated by an enzyme, 5-alpha reductase, and becomes something called DHT, or active testosterone dihydrotestosterone. If you've heard of the medication finasteride, that blocks this enzyme. Okay, so that's more in the prostate. It's used for male pattern baldness, lots of things. Doesn't really help for prostate cancer, but benign prostate issues. And then testosterone stimulates the androgen receptor. The active form of testosterone stimulates the androgen receptor even more. So we'll see that on the next slide. The adrenal gland is responsible for producing about 10 to 20% of your overall testosterone level. That mechanism and how that signaling, works actually isn't fully understood. It comes from the hypothalamus as well, but in terms of how much testosterone comes from the adrenal and why, if that's directly signaled, is a little difficult to tease out. So it's mostly the testicles for men. And then going into testosterone and prostate cancer itself, we kind of talked about where the testosterone comes from, testicles, adrenal gland here, and then it comes down, this is a prostate cancer cell. Testosterone gets in, turns into active testosterone, binds to the androgen receptor. That goes into the kind of working machinery of the cell, and that stimulates, we get growth, production, that's stimulating the prostate cancer to grow. Okay, so when do we take testosterone away? Why are we even talking about testosterone not being present? So adjuvant therapy for radiation, and then the next four categories of men are basically all advanced versions of prostate cancer. So castrate-sensitive, non-metastatic, high risk, castrate-sensitive, metastatic, castrate-resistant, non-metastatic. Oh man, all these terms, they give me a headache. I gotta break it down. But essentially, adjuvant therapy for radiation in patients who have advanced prostate cancer. And then we have low testosterone in patients that's just physiologic. We didn't give you anything to make your T low, but it is low, and you might have prostate cancer. So when we don't have testosterone, how do we feel? Not super great. We know that. I love this picture that somebody made us in a paper I cited there, but it's Michelangelo's statue of David, but on low testosterone. So, not great. We know not only do you increase fat, but unfortunately it's not like where you want it. It's not in the booty. It's in your belly. Okay, so we tend to have a redistribution of fat. You'll kind of get skinny arms, skinny legs, a little bit more in the belly. Not ideal, and it's also visceral fat, which is not good for you. We know that. And then decreased sexual function, all the things we talked about that testosterone does for us. When we take it away, you have a negative version of that. So your heart, increased cardiovascular disease. I kind of describe it as premature heart aging. Decreased muscle mass, decreased bone strength, increased risk of osteoporosis over time. So when do prostate cancer and low testosterone meet? So we've got, patients with low testosterone and symptomatic, and then those patients that have prostate cancer that are on active surveillance, or they're post-treatment. And when those things come together, it's always a question of what do we do with those patients? AUA guidelines, we have to do 2 early morning testosterons before 10 a.m., less than 300. That's what the American Urologic Association defines as low testosterone. And then symptoms, we talked about everything above. Just because you have low testosterone, if you feel like $1,000,000, you don't have to have it replaced. There are very specific people like a 40-year-old who I'm going to say you should have it replaced because you're going to have osteoporosis if you have low testosterone for this long. But in the elderly population, we don't necessarily have to replace it just because it's low. You also need to have symptoms. Okay, so then defining the patient. So a gentleman who just has physiologically low T, testicles aren't making enough testosterone, and they have low or favorable intermediate risk prostate cancer. So this can be low testosterone on active surveillance. And then physiologically low T, but you had a prostatectomy or you had radiation. And then pharmacologically low T. So I'm talking we gave you ADT and now your testosterone's low, but you finished your treatment for prostate cancer. What do we do with you? So those are all different clinical scenarios. That's why this always gets kind of complicated and it's very patient specific. So when did we as a community decide prostate and testosterone, prostate cancer, testosterone, they're bad. Testosterone's bad. It's a paper from 1941, and there was one patient who didn't have metastatic prostate cancer, 10 total, and this literature came off of that patient having a poor clinical outcome when he was given testosterone. So we don't base clinical decisions off of a study with a single patient anymore, but that permeated so deeply into our feelings about prostate cancer and testosterone that it's taken a really long time to back up and say, oh wait, okay, maybe it's not bad all of the time. So the American Urologic Association has a guideline statement. There are 2 guideline statements for testosterone replacement, and I just want to read them as is. Clinicians should inform patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. There is no literature that says if we replace low testosterone in a gentleman who, we're saying just in general, testosterone replacement, those patients do not show higher incidence of prostate cancer. So it is safe to replace testosterone if someone has low testosterone. Now, you have to be screened because that person could develop prostate cancer, and then we're working in a different clinical situation. But just giving someone testosterone when it's low isn't going to cause prostate cells to mutate and turn into cancer. So going on, next statement here. Patients with testosterone deficiency and a history of prostate cancer should be informed that there is inadequate evidence to quantify the risk-benefit ratio of testosterone therapy. What does that mean? It means we don't have literature that supports it's good or bad. We just don't have data to support it either way. And what that means is, guess what? It's on the patient and the provider to talk about risk-benefit ratio. You're allowed to replace it, but you have to have that conversation with the patient. we don't, as a community, recommend against replacement. Okay, so formal stance by the AUA. Opinion of the panel that until there's evidence saying it's unsafe, it's okay to replace it, but you have to have a risk-benefit discussion with your patient. And that totally makes sense. Okay, so that's that one. Okay, so when did we decide, okay, maybe we're overthinking this on the whole safety of testosterone and prostate cancer, like maybe it's okay. So there was a study that came out in 2008, and Morgenthaler reviewed multiple different studies that were both in animals in a rat model and people, and they presented what looked like a saturation model for testosterone. So what does that mean? Testosterone will stimulate growth of prostate cancer up to a certain point. And then past that, into physiologically normal ranges of testosterone, it doesn't really stimulate further growth. It's not like if I give you more T, you're growing more, and you're just hand in hand going up. It's that there's only so much the prostate is absorbing, and then that's kind of it. So, okay, show me the data. Well, here's the thing. There really is limited data that exists currently. So for active surveillance, my thought process on this is, if I have a gentleman who has normal testosterone and he has a PSA that's rising or something that indicates he has prostate cancer, he gets a diagnosis of low-risk prostate cancer or favorable intermediate, and I'm going to say, we're going to watch you, we're not going to treat you. I'm not going to take away his testosterone, right? He gets to keep living his life with his physiologically normal level of testosterone. And so we also know that patients who develop prostate cancer and their testosterone is low tend to have more aggressive prostate cancer, higher risk prostate cancer. So to me, it's like, well, maybe it's okay. It logically makes sense that having someone have a normal testosterone level isn't really going to make their cancer grow faster. It'll either progress or it won't, but they just have to be watched really closely. So what we have available for data, this is the one study that's cited by the American Urologic Association guideline for the statements they made previously that were presented. And that included 75 patients, 1 year of testosterone replacement therapy. That's not a big group of people, and that's not a very long period of time. So obviously, those are immediate limitations to applying this study to the general population. But they did a biopsy at the beginning of replacement, and if patients had high-grade PIN, which is a higher risk feature we consider for developing prostate cancer in the future, or not, and they looked at that, and there was no statistical difference. There was no statistical increase in developing prostate cancer for the patients who had the higher risk features on their biopsy. So what else do we have? There are some other studies. This came out recently. It's a big analysis of a National Cancer Institute and Medicare database called the SEER database. And so there are limits to just data mining previous outcomes that are reported on a database like this. But there were 167 men who received testosterone replacement with a diagnosis of prostate cancer that they were being surveilled. And then there were about 6,600 men who did not receive testosterone replacement, but there was no difference in their cancer progression need to go to treatment. It was the same. And then there are several other smaller studies that were included in an update, an AUA update. But again, these include small numbers of patients. Moral of the story, there's no data that says it's unsafe. So if you talk to your patient and you come to the decision to do it, that's an okay thing to do. You just have to have that conversation together. Okay, how about after a prostatectomy? Well, we know it's pretty safe, the data that does exist, it's pretty safe to give to people who have good features. So lower stage of cancer, their PSA is undetectable after surgery, and they had favorable pathology. So there was no invasion into the seminal vesicles, which makes them higher risk. Their lymph nodes were negative, that kind of a thing. It's maybe okay for people with higher risk cancer, but maybe not. And so that's what needs to be studied, is to know if that's going to impact overall survival long term for patients. There are several studies that were cited. All of them have smaller patient volumes. They still need to go for longer periods of time. The main takeaway from the AUA update and recent literature review is there actually were some groups that showed better survival in the patients who did have testosterone replacement therapy. So I thought that was interesting. But again, it's just a trend, and we need to actually have longer term data for that. Overall, pretty safe, it seems like. So post-radiation. Okay, there's a couple reasons why testosterone's low after radiation. One of the reasons is testicular dysfunction just because of the radiation itself. So there can be a change in your testicular function with an exposure of 2 gray of radiation. And it's estimated that after pelvic radiation, the testicles can receive up to 8 gray. And so we usually quote an incidence of anywhere from 22 to 59% of men can have low testosterone after radiation. And then we give hormone blockade to a lot of those patients. So we've made their testosterone go down. So those are the kind of 2 separate reasons we might be treating someone. And this paper, just to kind of highlight, after hormone blockade, that's a specific patient group. So after hormone blockade, not everyone's testosterone will recover. I mean, I really try to harp on that, but the longer you're on the hormone blockade, the less likely you are to have your testosterone recover. So this red line are individuals who received hormone blockade, ADT, androgen deprivation therapy. We love our acronyms. So ADT for 36 months, there was only a 23% recovery of testosterone at 5 years. 10 years, 44%. So those gentlemen really are not, a lot of them, the majority of them will never have their testosterone recover. So as a provider, we need to be talking about this. Like, so do we want to wait for your testosterone to recover? It's probably not going to. If you only got it for 6 months, better chance on that. And if you just have a little testosterone deficiency from the radiation itself, and maybe you'll have a recovery spontaneously, we should probably leave those people alone. But that's a big thing to consider. When I'm counseling patients, this table is nice. I tried to highlight it so it wasn't so annoying to read, but it did not work well. So when I'm trying to educate patients, what's the likelihood that your testosterone will recover after we give you hormone blockade? The main predictors are age, so over 65, how long you're on hormone blockade for. Are you doing 6 months or are you doing 36 months? And what your baseline testosterone is before you start treatment. I don't routinely get testosterone levels before starting ADT, but I think it's probably something I'll start doing more often to give people a better idea of maybe what their outcome would be long term. And then this study also showed diabetes as a risk factor for prolonged testosterone recovery, but the main 3 are age, baseline testosterone before therapy, and how long you're on the therapy. So there were some studies, again, cited, limited numbers of patients, follow-up long but not that long, and the 2 studies that did show recurrence of cancer after radiation and testosterone replacement, they were higher risk prostate cancer patients. So here's how I think about testosterone replacement therapy. If a patient is cured, then giving them testosterone will not magically make prostate cancer cells appear out of nowhere, okay? So if we take someone's prostate out and all their cancer was in that prostate, and I give them testosterone because they have symptoms of low testosterone and they have low T, I'm not going to magically create prostate cancer cells, right? So it should be pretty safe for the patient who has a high likelihood of having been cured. Let's go here. But if a patient still has cancer somewhere, are we pushing up their timeline of when they would have biochemical recurrence? And does that impact their overall survival? And that is what we need more literature for. And unfortunately, that's going to take, well, not unfortunately, it's good that prostate cancer grows this slowly and progresses this slowly. But on average, a gentleman will live 12 or more years after biochemical recurrence. So that's a long game if we're going to study something and show statistical significance. And then canary in the coal mine. So if we're giving testosterone and then we're seeing a PSA come up, is it kind of just letting us know someone has prostate cancer and then we go down the treatment algorithm for that they've had recurrent disease and now we need to treat them? Or are we actually shortening their life expectancy? So again, more data. And then testosterone remaining low is essentially the same as prolonged hormone blockade, right? And we have shown that if we block someone's testosterone level for a longer period of time with radiation, they do have improved outcomes. So that's why it's like, is it a good thing to replace it in a high-risk patient? That I'm not so sure about. This was a really interesting study, to me at least. I don't know about to everybody, but in 2009, this is a radiation oncology paper, and they looked at 206 men with unfavorable risk prostate cancer, and they got 6 months of hormone blockade or not. And then it looked at time to testosterone recovery. So how long did it take for their testosterone to recover? And the men on the red line, it took more than 2 years for their testosterone to recover. And they had a better overall survival. So that's interesting. They did control for a lot of confounding variables. They controlled for other medical conditions, things that could make someone just overall health poor. There wasn't a significant difference in their Gleason grade of prostate cancer. And then they looked at specifically prostate cancer specific mortality. And the prostate cancer specific mortality was higher in the group who had immediate return of their, like a faster return to their testosterone recovery. And it was at 8 years, 0% in the patients that it took longer than 2 years to recover. So I think what that says to me is we need a little more data, and I think in the high risk prostate cancer patient, it may not be beneficial for everyone. That being said, I have personally had gentlemen who are essentially suicidal because of the side effects of low testosterone. So guess what? We could probably replace their testosterone, right? Risk benefits. Gotta be a discussion. It's not black and white. So everybody, I say it's like that book, you get to pick your own adventure. I'm gonna give you where you can go with your story. And as long as we do it safe and have close follow-up, I'm open to those discussions. It's just, it may limit someone's life, overall survival. Okay, so can high-dose testosterone be therapeutic? There are a couple of really cool case reports that look specifically at a individual person's PSA levels. Okay, so this one, it was a 65-year-old gentleman, And this is his PSA level. So we're going into the hundreds here, right? Very advanced prostate cancer. Gleason 9 had had surgery, followed by radiation, had biochemical recurrence, metastatic disease. At the time when they were going to do the high dose testosterone, his PSAs were in the 500s to 600s. They did a blood sample to get some of the cancer cells and look at the genetics. And for this patient, the androgen receptor, that receptor that binds to testosterone, was over amplified 16 times the normal level. So he had a really over amplification of the androgen receptor, and his prostate cancer was growing even though his testosterone was 0. So they treated him with high dose topical gel testosterone, and his PSA came down to 46, which is cool. And he felt a lot better, okay? Felt way better, had a little reprieve of the symptoms of having low testosterone. Now, he obviously did not have good prostate cancer. His PSA came back up, but the cool thing here is they gave him abiraterone, which is a treatment, an androgen receptor, essentially a second line, well, an anti-androgen, we'll call it, and he responded again. So he was castrate sensitive. And I know, I'm sorry, I could do a whole talk about castrate resistant, castrate sensitive, but I'm sorry, I'm using these terms as they're going over your head a little bit. But for this patient, what it meant was his prostate cancer was now sensitive again to the fact that his testosterone had gone back down to 0. And so in this patient, it was helpful for him. There's a transformer trial, and this went through, they compared giving people enzalutamide alone, anti-androgen alone with their leuprolide, or if they did BAT therapy, bipolar androgen therapy, and that's where you go back and forth between high and low testosterone levels. It didn't show as robust of an outcome as you'd like, but it did show an improvement in progression-free survival. No differences in overall survival. But I think that that's still kind of limited. To me, I think for high-dose testosterone therapy, it seems favorable. There's some case reports that show some great data, and patients actually have a symptomatic improvement when they're on their testosterone, which is awesome. And obviously, we need more data, and there are multiple studies that are ongoing. What I think it's going to be for a very specific advanced prostate cancer patient who has an overexpression of that testosterone receptor. That's probably going to be the patient that will benefit the most. Okay, 12 minutes. We got this. Okay, we're going to talk about nutrition and prostate cancer. And I do see that you guys have a nutritionist coming soon for a group talk. So hopefully I'm not presenting any contradictory information. But at the Rocky Mountain Urologic Society meeting in April, a urologist from NYU, Dr. Stacy Loeb, came, gave us some talks about nutrition. She focuses on that. So this is a lot more what she was presenting on. So here's the big takeaway. Everybody asks, can we talk about diet? What can we do? Don't miss the forest through the trees, okay? 97% of patients with prostate cancer have a 5-year disease-specific survival. So 97% of men are not going to die from prostate cancer in a 5-year period. Low-risk prostate cancer, more than 9 times more likely to die from cardiovascular disease than prostate cancer. Metastatic prostate cancer, 17% of those men die from another reason, mostly cardiovascular disease. And cardiovascular health also impacts things that are super important to all of us, our sexual function, erectile function, quality of life. So you got to pay attention to more than just the fact that you may have prostate cancer, because that's not the only part of your body. So specifically, though, with regards to prostate cancer, there was an interesting epidemiology study that looked at Japanese men who moved to Hawaii, and they looked at rates of prostate cancer. And they did see an increased rate of prostate cancer, incidence of prostate cancer in the first and second generation Japanese men who moved to Hawaii compared to their counterparts in Japan. Still lower than Caucasian males, because genetically Caucasian males have a higher risk than someone from Japan. But that would suggest that the environment is influencing the risk of prostate cancer, right? Correlation doesn't mean causation, but that's an interesting finding. Okay, so let's talk about the American diet. Yay! This table is so upsetting. So, our carcinogenic classification. I don't know if you are aware. Processed meats, bacon, smoked sausages, salami are considered a class 1 carcinogen. And red meats, beef, pork, lamb, are a 2A carcinogen. What else is on that list? Class 1, smoking, arsenic, asbestos. Those are considered class 1 carcinogens. Class 2, DDT, lead, mustard gas. And those are things we're eating, and sometimes a little too much of. So why does that happen? There is the formation during the cooking process of some of the processed meats, and the red meats forms heterocyclic amines, and it can change hormonal effects, and so those things, really colon cancer, but we'll talk about that a little bit, impact your gut, impact the bacteria that are in your gut, and are basically just like a kind of chemical you're exposing to your intestines that you're then trying to absorb and process. And also, the nutrient composition doesn't have as much anti-carcinogenic compounds. So I mean, if you ate a pound of blackberries with your hot dog, maybe that would be better. But the reality is, maybe if you're eating a lot of those processed meats, you're probably also not eating a lot of fruits and vegetables too. So all of these things kind of go hand in hand. All right. So Dr. Loeb did present this literature, which I was not aware of. It's interesting, but it did associate whole milk consumption with an increased risk of prostate cancer recurrence. Now, non-whole milk wasn't associated with it, so I don't know what that means. I would take that with a grain of salt. I think it's okay to have milk. But she did specifically present on that, so maybe avoid excess amounts of whole milk consumption is what that would suggest. I don't know how many people are just drinking cups of whole milk every day, but maybe don't do that. Okay, and then this is just some more data that's more focused on kind of the impact of plant-based food in your diet. So there's about 1,400 men in this survey, and a higher consumption of healthy plant-based diet was associated with a lower probability of having elevated PSA. Okay. And then there's another study, a cohort study, looked at a lot of patients that Dr. Loeb has been working on, and a greater plant-based consumption was associated with 19% lower risk of fatal prostate cancer when it was adjusted for BMI, physical activity, and other potential confounders. But the cool thing about this is less than 1% of patients were strictly vegetarian or vegan. So the improvement was associated with the proportion of plant-based diet that was present in the patient. So the more plant-based you can be, the better your outcomes, but it doesn't mean that you're not eating any animal protein. Okay, couple other studies that showed, primarily just with in terms of being vegan or plant-based, that there are several studies that have shown you'll decrease PSA, fewer progress to treatment on active surveillance, and then patients who were in the control group more progressed to treatment, they had higher PSAs. And then again, for biochemical recurrence, there were 3 trials, and looking at, an increased median PSA doubling time. That's a good thing. You want your PSA doubling time to be slower. So the PSA was rising in the biochemical recurrence less in patients who had a more plant-based diet. Okay. So yeah, we should all be vegan. Okay, maybe not so fast. So the problem is there's actually literature that also says, depending on what kind of protein, what source of protein in an elderly patient over age 70, that animal protein's processed a little bit differently than plant-based protein. And so technically, the Academy of Nutrition and Dietetics says, a healthful, nutritionally adequate vegan diet, may provide health benefits and prevent chronic diseases, advancement of chronic diseases. Also says it's appropriate for all ages. But there are a lot of common vitamin deficiencies. It's incredibly hard to be a healthy vegan. Very difficult. And if we're worried about processed foods, it's also, if you're just trying to be vegetarian, it's difficult to do that and not have a lot of processed food in your diet. And then we have many studies that showed being prolonged vegan, which most people aren't doing it in a perfectly healthy way, increases the risk of bone fractures, sarcopenia, that means loss of muscle mass, anemia, and depression. Okay, well, we don't want our diet to do that either, right? So you can do something in the middle. My big takeaways are heart healthy is prostate healthy, because it's not just prostate cancer. We're treating a patient, and there's more than one organ in your body, okay? Whole food, plant-forward diet. I always tell my patients, try to cook everything at home. Try not to eat food out. Try not to eat pre-prepared frozen food, things in cans. There is a lot of data that shows processed food is bad for overall inflammation in your body. It's proven to be associated with some cancers, colon, ovarian, breast. It hasn't been proven to directly increase the risk of specifically prostate cancer, but how could that not be beneficial for someone? And we know it's good for your heart, okay? And then, let's see here, go back. Limit your red meat and processed foods. Increase your activity level. Let's see. Yep, perfect. One of the reasons why on that, if you're not on hormone blockade, but you might be later, let's build up that muscle mass now, that bone health now, okay? Do it before we have to maybe, unfortunately, take away your testosterone. And then, unfortunately, we've studied it a lot. There isn't any specific vitamin or supplement you can take that decreases recurrence or risk of developing prostate cancer. Okay, so in summary, testosterone is pretty darn safe, all right? Replacement should bring someone to a physiologically normal level. We're not really trying to overshoot, but it's safe to replace a man's testosterone. Testosterone replacement therapy for high-risk patients who have been treated for prostate cancer, yeah, that needs to be a discussion, and we really have to know, why are we replacing it? What are our goals? High-dose therapy, I think it could be helpful for some people with advanced prostate cancer for sure, but that is still being evaluated. And then, biggest thing, increase your physical activity, increase the plant-based portion of your diet, Mediterranean, trying to do something that's a good middle ground that's sustainable, and just limit red meat and processed meat, because that's just bad for us, apparently, even though bacon is pretty delicious. So I do still eat bacon. I just don't eat it every day, right? Okay, there's a middle ground. But that is it. So we can do questions.
I think, okay. If you have a patient on active surveillance, how often are you thinking about doing scans and biopsies?
Yeah, great question. So I'll answer that like whether they're having testosterone replaced or not, because the American Urologic Association says you follow those people the same. So we don't increase the frequency of PSA checks if someone's receiving testosterone on active surveillance. But for me personally, it's a little patient specific sometimes. I typically do PSAs every 6 months, and then I like to repeat a biopsy between 12 to 18 months, 1 to 1.5 years. If I'm suspicious that the biopsy didn't really capture what someone has, like their PSA is really high, but they had one core of low-risk cancer, or their MRI showed a really large lesion, then I'm like, nah, there's no way you only have one core. We got to do that again. I'll biopsy someone within 6 months. I'll repeat a biopsy sooner. But typically, I do that, and then after that, I want to mix in MRIs, and I like to biopsy at least every 3 years. Even if a PSA is stable, I believe in a repeat biopsy because I've seen a couple patients have a stable PSA, but their Gleason grade still changed.
Hello. Question, how high a dose in your replacement therapy are you considering? For example, I think Morgenthaler considered doses over 2,000 and that sort of thing. The normal male testosterone is somewhere between 1,000 and, as you said, 300. So I was kind of curious. Some of the benefits of really high dose seem to kill prostate cancer.
Yeah, so these studies were going for the literature that I reviewed. They were getting doses that were not as high as 2,000. Specifically, I know the dose for that case report, his testosterone was about 1,100 afterward. So yeah, the question is if we go crazy high, would it kill it? I think it all kind of comes down to you still have the saturation model, and maybe going crazy high would help the cancer to down-regulate its overproduction of the androgen receptor, which would then make it more sensitive to other treatments. But I'm not a biochemist, and from a physiology standpoint, I really can't define a mechanism in which super high testosterone itself would kill the cancer. I just think it would change the way that it's growing.
Thank you for a wonderful talk. You spoke about testosterone, but my understanding is that the dihydrotestosterone is much more potent form of testosterone. So is there any danger to overall health from taking finasteride or Avodart for long periods of time, many years?
That's a really great question. So when you're on finasteride or dutasteride, it doesn't necessarily change. It changes the level of dihydrotestosterone primarily locally. And so primarily in the prostate, for prostate cancer growth, and then going more toward hair loss with hair follicles being associated with high levels of dihydrotestosterone. That's why it helps with hair loss. But people have been on it we've been giving that med out like candy for a really long time. There is no clear association with that it's going to decrease your bone density or heart health like that. There is more emerging data that it may change sexual function more than we realize. And there's something called a post-finasteride syndrome. And I always educate patients when I put them on it now that there is a possibility they could have a change in their ejaculatory or erectile function in a way that actually may not even recover after we take them off of it. But in general, those meds don't really cause like the same kind of outcome as just having low overall testosterone. Yeah. Mm-hmm.
I'm curious about the side effects that lead to thoughts of suicide.
Oh yeah. Okay, so you know what? Hot flashes for some people are just really severe. It wakes them up at night. It makes them uncomfortable. They're just sick of it. Some people have mood disorders that are just not well controlled when their testosterone's that low. They're seeing their behavioral health providers are on the meds that are prescribed, but they're still struggling with their mood. And then sexual function is incredibly important to certain gentlemen. And if your testosterone is below a certain level, you have erectile and ejaculatory dysfunction. And so they would rather be alive, living their life normally for less time, than have low T and live longer because of their cancer. So. Okay, thanks everybody.
Thank you, Dr. Mihalko. Our next presenter is going to be Dr. Greg Franklin. We're going to take a 5-minute break.